Today we have a 65-year-old male with a past medical history of hypertension, diabetes type 2, CKD, presents to you for chest pain. He states when he walks 6 blocks, he gets a pressure sensation in his chest that is relieved after a few minutes of rest. He undergoes a stress test, which is positive for ischemic changes in the anterior leads. His creatinine is 2.3 and his BUN is 30. The patient is scheduled to undergo coronary angiography. Which of the following is the best course to reduce his risk of contrast-induced nephropathy? Welcome back to Medcomplete Board Review. So the answer to our previous question about our 65-year-old male who's hypertensive and has CKD and is about to undergo a cardiac cath, the answer is D. Give isotonic saline before and after the cath. So contrast-induced nephropathy is very high yield for the boards and is something that we all should be present of in real life too for our patients. It is something that we can absolutely do something about, and if we understand it well, we can prevent it. So the key points to learn is which patients are at increased risk for contrast-induced nephropathy, and this doesn't just have to do with cardiac cath. This is any sort of contrast, whether it be for CT angios, CT of the abdomen and pelvis with contrast. Whenever you're giving contrast, you want to identify these patients. The biggest risk factor for developing contrast-induced nephropathy is the presence of underlying CKD, okay? The lower the GFR, the higher the risk. So if you have a GFR below 60, you're at increased risk. Below 30, you're at the highest risk. Okay. Other risk factors would include presence of diabetes, presence of heart failure, certain medications, if you took NSAIDs before, but by far the largest risk factor is CKD. Okay. The best thing that we can do to prevent that is to give isotonic saline before and after the procedure. Okay. We'll go over that last. Let's just go over the other options. Steroids do not do anything and have not been shown to reduce the risk. Sodium bicarb does reduce the risk of contrast-induced nephropathy, and it's very similar in risk reduction to isotonic saline, but it's not preferred because it's very expensive and it takes time to compound and make. But there is evidence that sodium bicarb does reduce the risk. Okay, so I want you to know that, but it will not be the correct answer on your boards. The correct answer on your boards will always be to give isotonic saline, whether it's normal saline or LR. Okay. N-acetylcysteine is the one that had a lot of controversy about it in the past. Some doctors gave it, some doctors didn't. There was some data to show that it does help a little, but the largest meta-analysis that was done showed that it had no extra benefit and it wasn't statistically significant. So it's fallen out of favor. It's not used by many physicians today, and on your exam, it will be the wrong answer, okay? So just make sure, do not give N-acetylcysteine and do not pick it on your test. Pick the isotonic saline. Hypertonic saline also doesn't work. Okay. Now, high osmolarity contrast, this answer is going to be there when you do your exam. High osmolarity contrast is something that we don't use now. Okay. One of the things that does reduce the risk of this occurring is to give isoosmolar or hypoosmolar contrast, which is the preferred type of contrast that's used now because it has significantly less chance of causing damage. Okay. Now, as far as the isotonic saline, the question is, well, how much do we give? Okay, so you got the right answer here, but in real life, how much do we give to reduce the risk? Well, that depends if you're doing the procedure from an outpatient setting or an inpatient setting. So if the patient's coming from an outpatient setting, the preferred method is to give about 3 cc's per kg, 1 hour prior to the procedure and during, and then you can transition to 1.5 cc per kg per hour for 6 hours post the procedure, okay, and that will reduce the risk. In cardiac cath specifically, the amount of contrast we give is also highly coordinated with the risk. So the more contrast you give, if it's a complicated cardiac case, they have to give more contrast. That has a higher risk of causing damage. So obviously, like the typical case would be if somebody is going for an elective procedure, like an elective and STEMI cardiac cath, that's going to be less risk than, for example, an emergency, like a STEMI, where they have to go in now and sometimes they're a little bit liberal with their contrast that they give, okay? So elective procedures have less risk than emergency, okay? So if you're in an inpatient setting and you have a lot of time to try to reduce these risks, you can give 1 cc per kg 12 hours pre the procedure and 1 cc per kg 12 hours post the procedure. You could do 6 hours before and after, but if you could do 12, that's actually a little bit better, okay? I hope this helped, and if you guys have any questions, please feel free to leave them in the comments.